Good morning and afternoon, everyone. This is Holly Howard from the National Quality Improvement Center. We would like to welcome you today to the Chlamydia Learning Collaborative's Quality Improvement Methods 101 webinar. Thank you so much for joining us today. Our two faculty speakers for today will be Meredith Carroll and Amanda Cornett from Population Health Improvement Partners.
So here's our agenda, our roadmap for today's objectives. So we want to make sure we're going to start with an overview of QI principles and processes like we said. Then we're going to do a description of the Plan, Do, Study, Act cycle process. You will be submitting PDSA logs each month, so we're going to go into depth into that process. We're then going to talk about a case study demonstrating QI in action. So you can see how we want you to walk through this process and maybe apply some of these tools, and we're going to give you a really in-depth example. Then we'll discuss resources and next steps and a Q&A. And just like Holly said, please make sure to interact with us. We're happy for you to type in questions in the chat box. You don't have to hold them all until the very end, and we'll also have places for questions throughout. We also wanted to note here that this is going to be a high-level QI overview. We're not able to really go into depth as much as we'd like with all the tools just for the limited time. And we also know that a lot of you have differing levels of experience and expertise with QI. So this is high level. However, we do have some links we're going to provide you with throughout to some really in-depth video demonstrations of these tools. So if you need more information about a tool or want to read or look at more resources, then we can definitely provide you with that. We have some links in the important link chat pod over there, and then we'll also be chatting some links throughout. So just watch out for that. We're going to make sure to get you connected to any resource that you need. So without further ado, let's jump right in. First, we really just need to define quality improvement. What is it? What does it mean to us, and what do we mean when we say quality improvement or QI? So QI is a distinct continuous process. Continuous is really important. It's kind of a recipe of tools and methods that are applied to achieve measurable improvement. It's really important in QI to make sure you're collecting data and measures so that you can show that your changes are an actual improvement throughout your clinic. These can lead to changes in the efficiency, effectiveness, accountability, and/or performance of specific outcomes and other indicators of quality. So you can see here, again, it's a continuous process with measurable improvements to achieve specific outcomes. And we see these 4 key areas of specific outcomes in the services or processes that we provide. While QI has been used for decades in industry, in our case, and in general, when QI is applied within the healthcare sector, it is most often used for the purpose of improving the health and equity within an organization and/or for a community. So now we just want to really quickly go over the difference between quality assurance or QA and quality improvement or QI. These two sometimes get interchanged, but that is incorrect. They are 2 different things, and we just want to talk through the differences. QA is regulatory in nature. The philosophy is grounded in inspection and making sure services or products meet standards. So QA makes sure the system is following protocols in pursuit of a set of outcomes. It's often where we in public health and in clinical settings are actually focused, so we want to monitor and ensure that we have standard work to achieve a set of outcomes. Example of QA tools include staff protocols, maybe standard clinic policies, some competency skill checklists, etc. So just making sure that those protocols are in place and are being followed properly. QI, on the other hand, actually involves taking a step back and looking at the current system as it's being performed and focusing in to identify where there may be gaps or problems or clunky processes that could be improved to help improve the overall outcomes. And so where QA is focusing on the protocol to make sure we're achieving those set outcomes, QI is actually focusing on the outcomes to then influence how we can update and improve the system. So we want to make sure we're getting results that we want. In thinking about making improvement, we have to understand that each system is perfectly set up to achieve the results it gets. So if we keep doing things perfectly the way the system is set up, we still may not be achieving the results we want because it's only set up to achieve a certain set of results. So if we want to change those results, we need to change the system and really focus on where in the system we can improve. Now, we do like to say in QI that we're focusing on the system, not the individual. And so it's important that people know when we're coming in with quality improvement and trying to update and improve systems, we're focusing on how that system is set up and not how the individual is performing. QI can be used for lots of reasons to implement a new process or best practice. For example, if you wanted to introduce routine assessment of sexual activity into your clinic flow. It can be used to improve metrics where there is known low performance. For example, in our case, improving routine chlamydia screening for every sexually active adolescent patient. And it can be used to improve efficiency of a process. For example, reducing wait times, patient no-show rates, etc., or even redundancies in staff efforts. There are 4 key factors we're going to talk about today. We want to make sure when we're doing QI, we focus on small tests of change, frequent ongoing measurement, and data-driven decision-making. And remember that QI is a never-ending process, going back to that first visual. It is continuous. And then in the end, we want to make sure that it's helping staff, not hinder. So now, the QI process. If you Google QI, you'll find that there are multiple methods and frameworks to guide your efforts. For example, there's the Model for Improvement, Lean, Six Sigma, etc. All of these frameworks include key principles we will discuss today. So these basic principles include identifying the what and why you are improving, setting goals and measuring data and results to show that you're actually achieving those goals, observing your clinic flow, including all of its systems and processes objectively and holistically, so you can get a more complete understanding of your current system of care, of what is actually happening in your clinic. And then using that understanding of what we call your current state to identify opportunities for improvement and possible intervention points. We also want to have ideating or brainstorming on how to improve, so getting your whole team and clinic together to think through options to improve, and then testing your ideas to adapt the changes to your workflow. Now, each practice may use a different framework, but the key is to ensure that you have a standardized process that your entire clinic understands and uses. So for now, we'll be using this simple framework shown here. So now we're going to jump in to provide an overview of the QI process and each specific piece. We will quickly talk through each key piece of the QI process. Again, we cannot go in depth on every piece, so we're going to provide you with links to resources for more information as we go through the slides. So again, click on those links, take a look at those when you have a chance, and always ask us and speak up if you have any additional questions. So let's begin with the what, why, and the goals. When beginning a QI project, it is important to define the what and why you are doing the project and goals. This provides a vision for your work. So where are we aiming and why are we aiming there? The aim statement is a tool to help you clearly define the what, why, and goals. The aim statement describes what are we trying to accomplish. For example, what specific clinic program will our project focus on? Things like what is the problem we are trying to fix? And what is the overall goal of our project? The aim statement also describes why this improvement effort is important, who the specific target population is, when this project will be completed, how will it be carried out, and what are the measurable goals. For this project, we've actually defined the overarching what and why this is important, and we've outlined the specific project level goals. And you'll see that a little later when we talk through an aim statement. However, your practice QI team may need or want to personalize this more to your setting, your population, or your system. So talk through why is this important to your practice and the population that you serve. This discussion is a really great way to kick off your QI team's first project planning meeting. if you haven't held that yet. It helps to ground everyone and reinforce buy-in so that everyone has a say. Why are you doing this work? Once you have your aim and goals defined, and again, we've helped you out a little bit with that, but feel free to make it more specific to your clinic, it's important to completely understand how your current system of care works. Taking a step back to observe and more comprehensively understand how your current system works will allow you to see what is currently working and where there may be opportunities to improve. There are a number of means and methods you can use to more objectively and holistically examine your current system of care. Here are the ones we really recommend for this project. First, reviewing your clinical patient data. As part of this project, you are reviewing patient charts to determine your current sexual activity assessment and chlamydia screening rates. Often, this chart abstraction process will identify opportunities for improvement right away. For instance, you may realize that your practice does not have a standard protocol in place for where and how your clinicians and staff should be documenting sexual activity assessment results in your EMR. This is an issue we see a lot. Or perhaps you do have that standard protocol in place, but you discover that it's not being utilized consistently. So that's something you may want to address. Also, you want to make sure to review your practice systems inventory and the staff surveys that we sent out at the beginning. These staff surveys help you to identify your staff's current knowledge, attitudes, and practices as it relates to assessment and screening. It provides you an opportunity to understand if there are gaps in knowledge and then create a plan to support staff as they learn more. Our intent is that the webinars and resources from the eLC will help improve overall staff knowledge in your clinic. Also, the systems inventory will help you to examine the practice protocols you currently have in place related to assessment, documentation, screening, etc. The inventory may help you prioritize where you need to focus improvements of the system. For example, a best practice for assessment is to train and ensure all providers use a standardized assessment. If you examine your current system of care, you may find that not all providers use a standard assessment, and it may be something you want to implement. The other two that we won't go as in-depth with today that are really important is to observe and map a clinic flow. And this is really important so that you actually understand where your current state is at today. A lot of times you'll ask someone, oh, well, do you do this every day? And they'll say, oh, sure, I usually do that. But when you take the time to go observe a patient walking through the clinic, you may realize that it's not done every time. That may be due to short time, you don't have enough time with the patient. It might be due to you don't have the correct forms in the room, and so you're not able to do that without leaving the patient. There are lots of reasons why certain protocols in a system may not be getting done, and that's fine. It's just important to know what's happening. So we recommend having one, maybe 2 or 3 people in your QI team going out and actually walking through patient flow with a patient with their permission and documenting what happens. Did anything strange happen? Were there standardized practices? How long did each step take? And just documenting that so then later we can look at that flow and see where we can make improvement. And we'll talk a little bit more about that in a bit. And then, of course, talking to staff and patients. Your staff and patients are your #1 experts about the current process and what is happening in your clinic. So always ask questions, listen to what they say, and use all of these resources to help you make improvements. After you have a more comprehensive picture of your current system, you can then begin to brainstorm and identify various ideas for how your practice might adjust protocols to improve outcomes and close clinical gaps. We call this brainstorming step in the QI process ideation. The best ideation occurs when you can create a safe space for staff of all levels who work all along the clinical flow process to participate in the generation of these ideas. So getting everyone together to generate ideas will give you the best outcome. There are many different QI tools to help your team brainstorm ideas to improve your system. Again, we don't have time to dig into the various tools that can assist with the ideation process, But we did want to note that there are many, and you can see a few of them here in our Ideation toolbox. Again, we have quick online videos. These are all about 4 to 5 minutes apiece that explain each tool that we are discussing. So depending on the aim of the project, different QI tools can help your clinic QI team identify wasted time and inefficiencies in your clinic flow. It can help you identify root causes that are leading to clinical gaps or problems, can help ensure standardization of your process, or work towards a more ideal system, a future state that your clinic QI team can envision and design. We often find that your staff and providers will already know where there are issues, where there are so-called beaver dams or holdups in your clinic flow, where processes are clunky, etc. And if you have a really good quality improvement team made up of multidisciplinary staff all along the process who are responsible for work, then they will already have a lot of ideas about how your clinic might be able to improve these processes along the clinic flow because they know that work inside and out. But these tools can be used to augment that organic process of idea generation, especially when you have a particularly challenging step in the process. So these are just organized ways to get that brainstorming session going. Lucky for you all, again, a lot of the ideation related to successful implementation strategies, including the development of specific clinical protocols and tools, has already been done by practices that came before you in this project. Your colleagues from previous cohorts of the CT-eLC have identified key best practices that have been successful in improving sexual activity assessment and chlamydia screening in primary care settings like yours. In the CT-eLC monthly webinars that start next month, you will have the opportunity to learn about best practices within each of the 4 focus areas for this project that may help you improve your system of care. Though, of course, you may come up with your own ideas to apply as well, and that is always welcome and encouraged. You may find that you have several ideas that you would like to try out, and you might need to prioritize these ideas to determine what to test and when. You may have used different prioritization tools in the past, and one we recommend is the impact matrix. This is just a really simple diagram you can draw up to prioritize change ideas based on the impact they will have on your overall aim and goals and the difficulty they will be to implement. So this is a really great tool we highly encourage you to use during your brainstorming sessions to prioritize top change ideas. Again, we do have a video that explains this in greater depth, and we encourage you to look that up if you would like more information about the impact matrix or other prioritization tools. Finally, once you have identified and prioritized an improvement idea and a protocol change, the next step in the QI process is to test it. We will share some of the best practices and protocol changes for you to consider. Again, however, it will be important for your team to test and adapt these changes to fit your particular practice setting, system, and patient population. So we'll provide initial best practices, and then you can take those back to your clinic and really morph them into what you need for your clinic. As part of our CT-eLC, you will use the Plan, Do, Study, Act cycle, or PDSA for short, to guide your team through the process of testing and adapting new protocol change ideas. So now we're going to do another quick poll and see how many of you have used PDSA cycles to test a new change idea. No right or wrong answer. We're just interested to see if you've used PDSA cycles in the past. This can be at your current job or clinic or at a previous job or clinic. Great. It looks like we have a pretty good balance here. So far, it's about half and half, whether you've used it or not. And that's great. Those of you who have used it in the past can help us and speak up on how you've used it, what you liked about it, what you may have tweaked with it. It's always great to get feedback from those of you who've used it. Thank you so much. For those less familiar with QI terminology, PDSA stands for Plan, Do, Study, Act. So this means first you identify a gap and plan how you will test a new protocol to address the gap. What will you do? How will you collect feedback to determine if it works? Then you'll implement or do that new protocol on a small scale. So actually test it as planned. Make sure to document your problems, your data, your observations. Then you study those observations to see if it worked. What went well? What didn't go well? Summarize what was learned. And last, you take action based on what you learned. You either adopt the intervention if you've tested it enough and you feel confident that it will work on a large scale. You can adjust or adapt it to test it again, maybe make some tweaks of things that didn't work well, maybe provide an extra form or something that needs to be added, etc. Or you might realize that this change was a really great idea, but it's just not a good fit for our clinic, or we can't implement this right now because of a reason. And so you might need to abandon that change and start fresh with another change idea. And that's okay, and we can help you through that process. So again, plan, do, study, act. As you test and learn what works in your clinic, we are going to ask that you record what you learned from your test in the PDSA tracking log. You can see a screenshot here. You'll actually enter that in Qualtrics each month, and we'll have a video on this later to explain this a little further. But again, if you have any questions, you can print that log off now and look at it, use it while you're working through it. And we're also going to have a PDSA planning form that we'll talk about a little later to help you when you're conducting PDSAs in your clinics and make sure you're capturing all the information that we're going to later need on the tracking log. So how does the PDSA cycle work? Well, first you start with a new protocol change that you think will address the gap you have identified. You begin with hunches, theories, ideas, those brainstorming sessions and prioritization sessions where your QI team decides what you think you should test. Then you test it on a small scale. We suggest 1 or 2 patients max to begin with. That way you can see how it works. Then you study what you did, maybe adjust or tweak the protocol based on what you've learned from the test, and then test the adaptive protocol change with maybe 2 more patients. Study what happened, adjust the protocol based on feedback again, and then maybe test with 4 or 5 new patients. You will continue testing and adapting and learning until you are confident that the change will result in improved assessment and screening rates. So again, start small, start with your hunches and theories on what you think might work, test very small, make sure to change and adapt along the way, continually seeing where you can make improvements, and then eventually when you're confident in that change, you can go to wide-scale implementation throughout your clinic. So quickly, just to summarize, some benefits of the PDSA cycle that we really want to highlight are that they help you avoid unintended consequences on a large scale across your entire clinic. If it doesn't work with one patient, it most likely won't work with many, but if you fail with one patient, it's not as big of a deal. You can adjust, make it a little better, learn from it, and then move on. This process also helps you gain buy-in from staff. Many staff may be unsure of the new change, and this will help them test the idea. You can show them that you have data to show that the idea will work, and they can also provide feedback into what does and doesn't work within their clinic flow. This also allows your team to gain confidence that this will work in your clinic. Again, it takes the pressure off your team to have the perfect idea the first time. Instead, you have an idea that you think will work, and you have the opportunity to learn and make it better. So quickly, we just wanted to leave you with a few of our best tips to ensure you successfully test a new protocol change. Remember, starting small means testing it with maybe 1 to 2 patients to begin with, instead of testing it with all patients in your clinic. We also want you to remember to test in a short time frame. This means maybe 1 hour or just the length of 1 patient visit, not for an entire day or an entire week. Also, have a learning mindset. It's okay if a test fails. You're testing it on a small scale, and a failure becomes an opportunity to learn. So it's not a huge deal if you fail with 1 or 2 patients. You can adapt and make it much better for the next time when you test on a larger scale. So again, that's a really quick overview of the quality improvement process. I know we did this really quickly. Colleague Amanda Cornett to walk us through a case study. And if you do have any additional questions, just please feel free to continue to type them in the chat box, or we can follow up via email after. All right, Amanda, I'll hand it to you.
Thank you, Meredith. Good afternoon, everyone. Good morning to some of you guys as well. So I'm going to walk through a case study, and this is just taking what Meredith just explained and really helping hopefully shed some light on how you can use the QI process to improve adolescent sexual health. And so I'm going to do it by narrating a story. So we're going to tell a story, and then we're going to stop and let you all reflect on it. So hopefully this will be able to really embed how you can use the QI process going through this eLC. So hi, our QI team just participated in the eLC. We pulled together our QI team and we began to think about, what is it that we want to improve? How do we really define what we're going to do? So we met as a team and we defined the what, the why, and the goals of our project. And we put that into a concise statement that we called an aim statement. We made sure as a team that we captured all the key components of a good aim statement as we were writing our aim statement. So we defined the what. What we want to improve was chlamydia screening rates. We defined the who, the target population. It was specifically for us, we were looking to improve adolescent patients ages 11 to 24. We also defined by when. We wanted to make sure that our aim was time-bound, so we were going to make these improvements by March 2020. We also talked amongst ourselves to think about how much was realistic that we could make some improvements. And we thought that if we saw a 10% increase from baseline, that would be a tremendous improvement for our practice team. So here you'll see this is our overall aim that as a team we agreed on, as well as the leadership in our practice. So this was the aim that got us going. Luckily for you guys who are participating in the eLC, you all already have an aim statement drafted by the National Quality Improvement Center team, and you can adapt that based upon your clinic, the age groups, as well as sort of the goals that you want to set. Once our QI team here at the practice had our aim and our vision of what we wanted to do, we know that we needed to really understand what we were currently doing within our workflow to assess and to screen patients. So the first thing we wanted to do was to collect a little bit of data. So first we pulled 50 patient visit charts, and we began to look at the assessment and the screening rate. This really gave us a good snapshot of how we were doing. So by pulling our charts, we found that at baseline, we weren't doing very well. We weren't screening, or we weren't assessing or documenting. So here you'll see our baseline, we were doing less than 1%. Which also impacted the data we collected for our screenings. We couldn't determine if we were screening because we weren't assessing. So as we were looking at our data, we knew we had room for improvement. So this just gave us, again, a snapshot to say, yes, we definitely have some room to improve our assessment and screening rates. As a team, we wanted to keep digging more to make sure we were understanding what our current system looked like. So we completed a practice systems inventory, and this helped us to see, okay, there are best practices we should have in place around chlamydia screening. How are we doing? What do we currently have in place and what's not in place? And this was very eye-opening. As we went through, you'll see we had some areas that we definitely could improve. And when we began to look at the sexual activity assessment, what we noticed was we weren't consistently giving a standardized assessment to all of our adolescents, and we weren't documenting in a consistent place. So we definitely couldn't tell if we were assessing, and if we were assessing, we didn't have that documented. So again, we knew we had some real good opportunities for improvement. those data gave us a really good indication of where we were, but we didn't feel like that was enough. So as a team, we wanted to do some patient observations and really look at our clinic flow to see how we were supporting assessment and screening across our whole entire system of care. So the team, we identified 5 patients, and each of us on our team decided that we were going to observe those patients. So my patient was first, and I started my observation as soon as the patient walked into the door. So the patient entered, they checked in at registration, and I began my observation. I documented what task the receptionist completed during the check-in, and then I also documented how long it took the adolescent to check in. The adolescent went back and sat in the waiting room until they were called back to the intake process. And I observed and I followed the adolescent patient to the intake process. I documented the task that the medical assistant went through as she was doing the intake process. I documented the time that it took to complete that intake process. And I also began to think about opportunities that we had within our clinic to really begin to improve assessing and screening. And so as I was observing, I was also documenting those opportunities for improvement. So I followed the patient through each step of our clinic process, entering the exam room, going to the provider exam, having labs completed until they exited. And for each of those steps along our process, I documented what happened at each step, how long it took, and I also documented my opportunities, the opportunities that I saw that we could improve our assessment and screening process and make it more consistent. All of my QI team members also did a very similar observation, and we came together and we wanted to make sure we all understood all the different observations that we had collected. So we chose to visually display all of those observations in a map. And our QI trainers called this a process map or a value stream map. And basically all we did was we took Post-it notes and we listed out first all the steps in the visit. So what we had observed, we just took and translated so that we had all the steps in the visit documented with the yellow Post-it notes. And then we documented the average time that it took the patient to go through each of those process steps. And so since there was 5 patients, we just took an average of all those patient times. We also wanted to make sure that we were capturing any time the patient may have had to wait. So you'll see here the pink triangles. That was a capture, just sort of an indication of the patient had to wait before they could actually go to the provider room. Again, all these things are part of our observation, and it began to paint a really clear picture of our workflow and how we were supporting the assessment and screening process. And finally, we all had great ideas for how we might improve our overall clinic visit to make sure we were supporting assessment and screening. And so you'll see here, we documented all of the ideas we had for improving our process with these stars. For us, this is very eye-opening to actually see the workflow, to see where we had opportunities for improvement. And so we're really glad that we took the time to set aside and look at both chart reviews, our inventory, and then this map. And it really painted a picture of, oh yes, we do need to make some improvements. And it gave us ideas for where we should be able to start. Now that we had our data, we knew we needed to improve. We had our process map, we had our inventory. One of the areas that we knew we needed to focus on was making sure we were using a standardized assessment and identifying a standard place to document the results. And so this was the opportunity for our team to come together and begin to think about, how can we improve this? What type of assessment, what resources do we have, and where do we begin with this process? Like you guys, we had the opportunity to attend webinars. So there was a webinar on sexual assessment. There was great insights, great resources presented during that webinar. And we also visited the eLC website where there was resources from our peer colleagues from previous cohorts. And so between these two resources, we really began to identify and brainstorm some great ways that we might be able to improve and standardize our assessment process. So as a team, we huddled together working together as a team, looking at all the resources that we had collected, and we identified what protocol change are we going to start with first. And the thing that we decided to do was to distribute a standardized assessment for all of our adolescent patient visits. And so that was where we were started. We were all excited. We knew this was the place to start that would help us begin to move our baseline numbers up. We're excited. We wanted to do it the next day, but one of our team members said, whoa, 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 let's not do that. Let's wait. What if we start using this assessment and force everybody in our clinic to use this assessment? They may be overwhelmed. They may be resistant to change. So let's slow down a little bit. Let's think about our parents and our patients. What if they become upset because we're introducing this new assessment? So let's slow down a little bit. Let's think about how we can try this out and test it out on a small scale before we actually implement it across our clinic. And so as a team, we sat down and thought about, okay, let's test this. We learned from our QI webinar to test it. So we used the Plan, Do, Study, Act cycle to test this new assessment process for our adolescent visits. So we sat down, we started thinking about, okay, how are we going to test it? And we actually used the planning form here you'll see on the right to begin to document how we were going to carry out this test. And we documented it so all of us on the QI team knew exactly how we were going to hand out the assessment, how we were going to collect data to see if it was working. And it really gave us a good way to document so that we were all on the same page about how to test this new assessment process. So our plan to test this new assessment process, we're going to test it small. We knew we didn't want to start large because we wanted to make sure we were learning and getting better. So we were going to test it with, we knew Dr. C had a patient coming up on Thursday at 9:15 within our age range. So we were going to test this new assessment form with Dr. C's 9:15 patient on Thursday. And the way we were going to test it was we were going to give it to the front desk, and they were going to hand it out to the adolescent to complete. And then after that, we would huddle after the patient visit with our QI team. We would huddle with our front desk receptionist, our medical assistant, and our provider to really understand how did this new assessment process go, how did the new assessment form go. And so that was our plan. We were going to do it at the front desk with the assessment. And we also began to think about as a team, why are we doing this test? That's a really important question for all of us when we're doing PDSA cycles. Why are we doing this test? And so we began to think about, okay, what do we want to learn as we're testing this new assessment process with our patients? Like you guys, as you all were chatting and as you're sort of voting, our team had lots of questions. You know, this was a new process. This was a new assessment tool. So, you know, how were we going to, what were the reactions of our patients and our parents and adolescents going to be to the assessment? Would our adolescents complete the assessment? How difficult was it going to be for our staff to review the assessment and document it? And how easy is it to find this information? So there was all kinds of questions swirling in our QI team members' head before we started doing this. And that's why we jotted this information down. We wrote it down on our planning sheet so that as we were testing, we could come back to these questions and ask, how did parents react? You know, did they complete the assessment? So it was just a really good way that we actually collected all of our information and made sure that we were capturing sort of our concerns to make sure we were testing it. So once we had a really good plan that our QI team, we were all on the same page, we knew what questions we had about this new process, we actually did it. We did it with one patient, our Thursday morning 9:15 patient. The front desk gave out the assessment, and then the medical assistant reviewed and documented the information. And immediately following, or somewhere around lunchtime, our team gathered to do a huddle. And so we asked the front desk staff how it was going. So Ellen, from our front desk, how did the whole process go of giving out the assessment?
Giving out the assessment was a cinch, but the parent had questions and hovered.
Oh, that's great feedback. So we didn't anticipate that the parent would be hovering over the adolescent all the time. That's really interesting, and I guess we didn't anticipate needing a script. So that's really good feedback. And Jennifer, from your perspective as a medical assistant, how did the assessment process go for you?
Well, reviewing the assessment was easy. All of the info was completed, but I wasn't really sure where to document it.
Great. Yeah, I think we had thought about documenting it in one place, but maybe we haven't been clear about that. Both of you guys give some really good feedback. So as we're thinking about how to test this assessment process again, I definitely want to make sure that we're tapping into you all to help us, figure out how we can have a script or some key points and then documenting this correctly. So thank you guys for testing this. I know that our team will come back to you to help us think through how we continue to make this better. So thank you. And that's exactly what we did. You all were right. You know, as a team, we got feedback from our medical assistants and front desk receptionists. And I think that's key, is always making sure you're getting feedback from those who are actually having to implement the change. And so based on their feedback, we huddled with them and really thought about what can we do to make sure that this assessment process goes well. And so that first patient, we tried it with one patient. The way we adapted it was we created a script that the medical assistant could use to provide information to the parent as well as the adolescent about why we were doing the assessment and the purpose of it. And then also a script, some key points that ask that the adolescent complete it by themselves. And then we also worked with our EMR guru and our MA and our provider to really think about where could we document this so that it was confidential and it was an easy, consistent place that everyone could access the information. And so we tested, again, the whole assessment documentation process, again, with 3 patients. We stopped and we huddled at the end of our morning visits. We huddled to see how things went, got feedback again from our medical assistants and our provider and our front desk receptionist, and we tweaked the process. And so we continued testing with morning patients the next day. We tweaked, we sort of thought about what we could do differently, and then we got to the point where we felt like the process was going well, our script was down, we were documenting, and we continued to test it for all of the patients for that week. So it really was a process of tweaking and learning as we go along to make sure that we are adapting protocols that's going to work within our workflow. And of course, as we were going along, we were documenting what we were learning, reflecting on what we were learning. So at the end of the month, our data coordinator, or data lead for our practice, could enter the information into the PDSA tracking log. And then we also collected chart reviews for 20 of our patients and submitted that via the data system portal so that, again, we can see if these changes are really making improvements within our system. And we were so excited when we got our monthly progress report back to actually see that our changes were making an improvement. So our data supported our feeling that, yes, we are making improvements. And so this was a wonderful victory for our team to be able to see that. So as you all are going through the eLC process, you'll be getting monthly progress reports as well that shows your data. We'll also give you some coaching notes from our coaches about how you might consider testing or tweaking your changes as you go along. So the data report was very helpful. And of course, we knew as a QI team that success wasn't happening in a vacuum. There were some keys that we definitely were thinking about for our team. So having a leadership and clinical champion within our clinic was helping us make these changes and be successful. That clinic champion really cheered us on, got staff supporting us when they were resistant to the change. And they also gave us time to really think about and plan our changes very well. Having a plan in place to make sure that we were all on the same page about what we were going to do and how we were going to test. Having our multidisciplinary QI team who had different perspectives about the clinic flow as well as different talents and strengths really helped us look at the different changes we wanted to implement and helped us really see things from a different perspective. Another key to our success in continuing to improve our assessment rate was getting all levels involved. So from the front desk to the medical assistants to providers to our lab, really making sure everyone felt involved and we were getting their feedback and making sure we were doing change with them, not to them, and making sure they were involved. And then, of course, the data. The data really helped us to continue to see if we were making changes. And so that data was very important, and those monthly progress reports we got very important to help us understand how we were improving in the areas that we were improving. So hopefully this little case study of how the QI process, from setting an aim to collecting data and mapping your process to then using the PDSA cycle to test changes, hopefully that helps you all see how the QI process will help you all as you participate in this eLC. I'm going to stop there. Any questions from you all?
All right, I think that's it, Meredith.
Thank you, everyone. Have a great day.
Thank you.
Thank you.
Thank you.